cardiac today. Next week on that Friday, I will repeat a lot that I'm doing today, so it won't necessarily be a whole new set of slides. I may add some things, but it's going to be a repeat, because typically what happens is I'm away Memorial week, so I fly out Memorial Day, come back in on Thursday, but several days, at least when I'm up in the air, I can send you questions. I like to just send questions to help you. So I'll send a bunch of cardiac questions and the rationales will all be there. I'll do the same with MS and Parkinson's. I foresee you guys will not have a problem with MS or Parkinson's. I do not throw any surprises. My lectures are pretty straightforward, and I do tend to focus more on the care, some of the signs and symptoms, not like the prevalence or epidemiology, so the care of Parkinson's and MS. All right, so I have right here. So the cardiac. You're welcome. There's two there, and we have extras as they're going down. Okay, everybody have one?
Yeah.
All right, let's start going through these questions. And I'll be going over some things as we go along. All right, so the first question, cardiac. A client is experiencing sinus bradycardia with hypotension and dizziness. What medication does the nurse administer? Atropine, digoxin, lidocaine, and metoprolol. So, which one would you want to give? So again, low heart rate and low blood pressure. Atropine, absolutely. So that's correct. We're certainly going to hold it if they have a low pulse. And metoprolol we give to someone with hypertension, but I don't want to bring it down any further if they're the blood pressure is already low. So atropine is the drug of choice. At what pulse level do you hold DIG?
60.
Less than 60, very good. So your ACE inhibitor, lisinopril, you're doing teaching. What's the biggest concern people have with lisinopril? Dry cough, absolutely. Someone on DIG, what is the side effect with DIG toxicity?
Visual disturbances. Halo.
Yeah, so it's really that hazy, yellow, greenish halo that they will see. So that's visual change. It may be said in other ways, visual change, but that's the key connection to DIG toxicity. So let's see. Diuretics. So we have some diuretics that potassium wasting. Furosemide. What other one would waste? Hydrochlorothiazide. So what is the issue with, so if it causes the potassium to go low, we need to add potassium. How do you add potassium?
Diet.
Potatoes, bananas.
Potatoes, bananas could be diet. How would you add it IV? Secondary. The first group told me slow IV push. No. Unless you're Dr. Kevorkian, you are never going to push potassium IV. It always has to go in through a pump, through a drip, minimum over an hour. So that's how we're going to give potassium. Okay, so what happens if we were to, the potassium with our diuretics is potassium sparing and we have increased potassium and it's elevated. What are we going to give them to decrease potassium? K-oxalate. How do you give K-oxalate? You're gonna drink it, or you can give it rectal enema. So either way, okay. Calcium channel blocker, your verapamil. What's our big concern, side effect, that what adverse reaction we're looking for? Biggest thing could be hypotension, orthostatic hypotension, so you may have to do postural signs. How do I know if someone's on dobutamine that it's working?
Positive side effect, a positive reaction, like positive.
Correct, but what is the positive reaction? Increase urine output, absolutely, very good. Let's see. So if I was to give someone diuretic furosemide and they had low potassium, because again, it's a potassium wasting diuretic, how would I know it without the labs? The lab's not back, but why do I suspect? What symptoms? Because we don't in the test say low potassium. That's way too easy. So what does low potassium look like to you? Tingling, yeah. Muscle weakness, yeah. So muscle weakness, leg cramps, fatigue, all of those should shout out hypovolemia. That's what you'd be looking at, because we'd say, patient who has muscle cramping, is on furosemide, instantly thinking of low potassium. So it would be way too easy for us to say they're low potassium. We're not going to do that. Okay, a client with a heart rate averaging 56 beats per minute with no adverse symptoms. What activity modification does the nurse suggest to avoid further slowing of the heart rate? So A, make certain that your bath water is warm. B, avoid bearing down or straining while having a bowel movement. C, avoid strenuous exercise such as running during the late afternoon. D, limit your intake of caffeinated drinks to no more than 2 cups per day. Which one here are we concerned that will actually bring the heart rate down lower than 56? B, your Valsalva maneuver is what's going to cause it. All the others will actually bring it up. That one's going to bring it down. The nurse assesses a client at a community clinic. Which client does the nurse assess most carefully for atrial fib? A, middle-aged client who takes an aspirin daily. B, client who is dismissed after coronary artery bypass. C, older adult client after carotid endarterectomy. Or D, client with chronic obstructive pulmonary disease. So what conditions lead someone to atrial fibrillation? What is it? So usually coronary artery disease would be a connection over to atrial fibrillation, and the only one here, someone who's had cardiac surgery such as bypass certainly could lead to an arrhythmia. So really the B is correct. You could carotid endarterectomy, but it's that surgery that could lead more to an arrhythmia more than just going and cleaning out the carotid arteries. So B is correct. So now, somebody who has atrial fib, what do we put them on? We're going to put them on warfarin. So we're going to put them on something anticoagulation. Maybe initially heparin going over to warfarin. What is the antidote for heparin? Protamine sulfate. So again, when you think of the heparin, heparin So that P, protamine sulfate. What is the antidote for Coumadin? Vitamin K, absolutely. What is the therapeutic range for the Coumadin, the warfarin? What's the, where do we want to keep them? 2 to 3. So the INR, we want 2 to 3. So, what symptoms would you be looking for? Somebody who has atrial fib that would warrant you to call the doctor immediately. Stroke-like symptoms, very good. So because we're not going to just say, because they're at risk for clot, we're going to say that they have maybe difficulty talking, drooping of one side of the face, weakness or numbness in one arm, one leg. Again, all the things that are at risk for a stroke. Slurred speech, dizziness, sudden severe headache, all the things that yell out stroke is what we're gonna call a physician for right away. The nurse scan for client with atrial fib. What manifestation most alerts the nurse to possibility of serious complication from this condition? Actually, we just did this. Sinus tachycardia, speech alteration, fatigue, dyspnea with activity. So our whole concern is that atrial fibrillation is going to shoot a clot, and yes, they could go into pulmonary embolism or stroke, and this one's saying stroke. Nothing here is saying pulmonary embolism to me. Dyspnea with activity would not say pulmonary embolism. So my one that's really shouting out a clot is B. Okay, so let's see if there's anything else here with, no, AFib, okay. A client's EKG tracing shows a run of sustained ventricular tachycardia. What is the nurse's first action? Assess airway, breathing, and level of consciousness. Administer an amiodarone bolus followed by a drip. Cardiovert the client with a biphasic defibrillator, or begin CPR resuscitation. A, you want to assess first. Just because the EKG shows a run of sustained ventricular tachycardia, you'd want to find out if indeed they are. Brushing teeth. Patient who's on EKG monitoring in a hospital, walking around, they go brush their teeth, comes out on the monitor looking like sustained ventricular tachycardia. Someone who could be in the hospital pulls a curtain, engages in sexual relations. Sometimes the monitor looks like sustained ventricular tachycardia. Everybody goes running in behind the curtains, and we're all more embarrassed than the patient. So you want to always assess first. A client with unstable ventricular tachycardia is receiving amiodarone by IV infusion. The nurse notes that the client's heart rate has decreased from 68 to 50 beats per minute. The client is asymptomatic. What is the nurse's priority intervention? Stop the infusion and flush the IV, slow the amiodarone infusion rate, administer a precordial thump, or place the client in a side lying position. So typically, we're going to say they still got a heart rate. We can probably rule out C, that I'm not going to do a precordial thump when they're still beating their heart. Side lying for somebody with perfusion problems, they're probably more, if it's really low, I'm going to be flat. Otherwise, they're probably going to be in a semi-followers to follow up their breathing issues. So probably can go down to A or B. Now, we gave the amiodarone because they had an arrhythmia. If I suddenly stop it, what could happen? The arrhythmia could come back. So I don't want to stop it completely, I want to slow it. So basically you'd be looking at these and saying, which one's better? And slowing it would be better, as I started it to get rid of the dysrhythmia to begin with. You will definitely have rhythms on the test. You will have to interpret. So number one is what? Ventricular tachycardia, again, that wide, bizarre QRS. So that's a typical one that you'd have. And then the bottom one is pretty typical too. Usually it's going to be your more common ones. I've never seen faculty put on like a first degree block or anything like that. I think I don't think they're going to put on a rhythm where you can walk around a unit. You're going to say one thing, you're going to say something else, and you're going to say another. And the cardiologist can say, well, it could be either of them, I'm not quite sure. So they're not going to give something that you're not going to know. So this is clearly ventricular tachycardia. What's this one? VFib, ventricular fibrillation. So yes. So you want to know the conduction through the heart. So yes, we start at the SA node going to the AV node going to
Bundle of his.
the bundle of his to the Purkinje fibers. So you want to know that, but more than that, you want to know like the P wave. What is the P wave? What does it reflect? It's going to reflect atrial depolarization. What about the, let's see, so you would do that through, so that's the P, QRS. Ventricular. So you would want to know what each wave formation, if I wanted, gave you a normal AKG, P, QRS, and said point, or it's going to be a hotspot, point to the area of the EKG that would show an issue with the myocardium. So it could be an injury or ischemia. Where would you point it? ST segment. Yep. So you'd point it to the ST segment. If somebody has ventricular fibrillation, what's the treatment? VFib?
Isn't it like CPR or something? Or
DFib. So you want to defibrillate. Okay, let's see what else I have. All right. A client is admitted with early stage heart failure. Which assessment finding does the nurse expect? A decrease in blood pressure and urine output, an increase in creatinine in extremities edema, an increase in heart rate and respiratory rate, a decrease in respiration and oxygen saturation. C is correct. So early stage heart failure, you know, the heart rate, there's fluid volume overload. So the heart rate, blood pressure, respiratory rate are all going to go up. So